who is Southwest and what are we here for? So I was saying to Tiffany this morning that I've always spoken with Tiffany at finance conferences, and I get invited to this Healthcare Financial Advocate Summit. And I'm like, okay, a whole bunch of people that work with hospitals, probably in the finance department. So we'll just use the same presentation. And then last night, I start hearing about this job title, this Healthcare Financial Advocate. I work with them every day at hospitals, but they're helping patients pay their bills and sign up for Medicaid. And all of a sudden, I'm hearing this job that they're independent contractors and they work privately with patients. And I was like, wow, that's fantastic. I didn't know it existed. We often work with patients that can't afford to pay their bills. Now, I'm guessing if you have private patients that can afford to pay your bills, they could probably afford to pay a lot of their medical bills. So this tackles a lot of the health equity. How do we help hospitals make more money? How do we help patients cover their costs? But we might divert a little bit and sort of show you some patient stories and how, for the healthcare financial advocates, the independent contractors in the room, how we can maybe help you do two things. One, grow your businesses, where in a hospital or a health center or a community, you might want to start looking to grow your own practices, because we see it every day. So we handle patients that can't afford their bills, but we also handle patients that don't know where to turn, don't have anyone to turn to, or their neighbor or their mom or somebody has gotten sick and they just need a ride and they don't know where to turn to get that help.
Yeah, so I'm Tiffany Poole. I'm pharmacy director. My background is in pharmacy. Southwest Mississippi native. I was actually born in the hospital in which I'm pharmacy director for. So we have definite roots in our area. Our facility is a DISH hospital. We rely heavily on 340B to keep the doors open and to keep things rolling in our facility. A large percentage, because we are a DISH hospital, is going to be a disproportionate share of patients. And so the opportunity to partner with someone who would help extend access to patients that previously we really didn't have the resources, we didn't have the bandwidth to pursue the grants that open, for 1 day or 1 hour every 2 weeks or every 2 years, And so this became an opportunity for us to expand the bandwidth of our existing patient assistance people and really tap into something that we didn't even know existed for our patients.
Okay, who are we? So I am a former investment banker. I'm in recovery from that lifestyle. And I came across, my background was in healthcare and investments, and also I had a computer science degree. And when I left investment banking, I was doing a lot of consulting for hospitals. And I came across this discovery that there are thousands and thousands and thousands of ways for patients to be able to pay their bills. But it was really, really difficult to navigate. So for about a week, I tried to tap into my 1992 computer science degree to see if I could program this myself. Let me tell you, that didn't go so well. 1992 programming is really different now. And so I outsourced this software development. And pretty much what we do is we have software that every day we log into our healthcare, our hospitals, EMR, the schedules, who's coming in, what are they coming in for. And we have a whole bunch of criteria that we look at, and we match them against our software. And using that technology, we can then sign them up for whatever they're available for, whatever's open, whatever copay card comes from Injector for that day, if they're getting that. Or Enhertu is another one I'm hearing a lot more about these days. And so we sign them up, and then we make sure their bills get paid, because you can sign up a patient all day long, but unless you're submitting the bills for them and getting that side of it covered, they're still going to get those bills in the mail. They're still going to get sent to collections when they can't pay their bills. And that's how we started working with hospitals like Tiffany's. Okay, so let me go back here, because it does this a lot. So why are we doing this? So I would say that Tiffany she's like an entrepreneur within her own hospital. This lady, she works as a director of pharmacy, but we're now getting free pacemakers, free Watchmans, free everything for patients, free employee drugs, which we'll talk about, for patients that can't afford it or patients that are uninsured. So here is one of the best stories. It's a lady, she had breast cancer. She was so sick that she had to leave work. She used up all of her FMLA, but wanted to do the right thing. She couldn't afford the $1,200 a month COBRA plan that she had. She had to leave work. She had to go on disability, but she wanted to do the right thing, and she got an Aetna marketplace plan. Okay, so she lost her insurance, couldn't afford COBRA, but she could afford the Aetna marketplace with subsidies. Unfortunately, it had a $10,000 deductible. She had a double mastectomy, and she owed over $8,000 for her treatment. She didn't want to go to collections. She wanted to go to bankruptcy. Again, trying to do the right thing. So she went on a $10 a month payment plan. It's going to take her 800 months to pay that bill. The hospital it wasn't going to get paid. We found her a grant. She lives in an area, much like Tiffany's, where there are some really attractive options to help patients. It was a $16,000 grant. It covered her $8,500 bill, and with the money left over, she was actually able to sign up for a much better insurance plan. It paid her premiums, so it paid her insurance as well. She burst into tears. She thought she was going to have to leave the area and move in with her daughter to Michigan just to try and cover this debt, because she didn't want to go to, people don't want to go to collections. People don't want collections agency calling them. She burst into tears, and that's one reason why we're doing it. Now, the other reason we're doing it is because financial benefits for the hospital. So here's another one of my clients, Gail, down there. And if we can't get the hospital paid, they can't keep their doors open, right? So you have a situation where deductibles, when I first moved to the United States, it was 1998. Pretty much I went to the doctor, it cost me $10. I went to urgent care, it cost me $50. I had an x-ray, it cost me $100. Like, it was easy. Now, I thought and I kind of know what I'm talking about in this healthcare world, so I bought a zero deductible plan. So I go and, I had some ultrasound. Mm-hmm. And they're like, okay, that's going to be, they give me my estimate, it's going to be like $750. I'm like, but I have a zero deductible. They're like, oh no, but you have co-insurance. And I'm like, what? But I have zero, I have no deductible. No, but you have a co-insurance, and until you meet your max out of pocket, you have a 20% co-insurance. Right. And these are the kinds of things that we're dealing with on a day-to-day basis just in understanding our insurance. Now, if I couldn't afford to pay that $750, the hospital was eating it.
Yes.
The hospital wasn't getting paid. And when you're in rural communities, in urban communities, inner city communities, anywhere, if you can't afford to pay your bills, the hospital's still going to treat you. They're just not going to get paid. You have $88 billion in past due healthcare debts in 2021. One in eight adults forced to declare bankruptcy because of healthcare debt. It's terrible for the patient, but it's also terrible for the hospital because they need to get paid. So what happens to the hospital? Hospitals typically collect less than 20% of a patient's financial responsibility. The higher the bill, the least likely it is. So I think it's pretty much you have like a 1 in 20 shot of getting paid for a bill over $2,000 if you're a hospital. We identify patients up front that have high out-of-pocket costs and try to search for alternate means of payments. And we try to avoid patients' healthcare debts being sold to collections, because if it's sold, hospitals are typically collecting 1 to 2% of what comes to them after it's sold. What else happens? Really terrible outcomes for the patients. You have patients choosing not to receive treatment because they can't afford their care, or they don't even know they can't afford it. They might be able to afford it, but they're so terrified of what it might cost that they don't even go to their appointment because they're just afraid of what the out-of-pocket cost might be. So Southwest, a little bit about the population.
Yeah, yeah. So we have, like I was saying, we have a very comfortable dish percentage.
Does everybody know what DISH means?
Yeah, disproportionate share.
It means they have a really big Medicaid population and uninsured population.
And so our facility, we have lots of elderly residents. There's a city and urban sect, and then there's also your rural communities as well. So it's a very mixed bag. You know, we're treating all sorts of different needs. We're treating all sorts of different economic statuses, you know, and the disparity there is really something as you all know, in Mississippi, in rural areas, in rural America, you know, you have people that live a long distance from these larger institutions and the larger health centers. And so whenever you can create an option for them to be able to get their treatment closer to home, you're increasing the chances of them being adherent to their care, and you're improving their outcomes. And so for us, we did have difficulty, you know, keeping up with how quickly the different access opportunities were rolling over. One thing would close, we'd miss it. We didn't have the bandwidth in our facility because we are in a rural area to track all of that. And so that is where we've really worked together to start a process and identifying how we can expand access for our patients. And that's where Monique's group has come in to really save the day for us.
Okay, so here are some options. There's actually a lot more now. I need to update the slides that we work with, but free medication. These are options for patients that are uninsured or so drastically underinsured, or insurance companies won't cover their bills. How do we get that medication to that patient at no cost, delivered to their front door, you know, every month? Over 1,300 programs that help patients with all kinds of assistance based upon their disease. So we just helped a young boy, he's 4. He has Pompe disease, and his poor family lives in Mississippi, and the only place they could be treated was in Jackson. It was like a 4-hour drive. They couldn't afford the gas to get there. So our local hospital that we work with, they set up a special little chair for this little kid so he can be treated. The family still can't, it's still a half-hour drive. This is, you know, this is a treatment that he has to go for, I think it's 1 full day every couple of weeks. And mum has to miss work those days. You know, we were able to get his insurance covered, and actually he was Medicaid, so it was insurance. We were able to get the patient a $500 transportation card that he can use every 6 months, obviously the patient's parents, that they can put gas in the car. We were able to get the patient a $500 urgent need grant that they can use for their groceries. It's based upon his disease of Pompe. There's a lot of cancers, sickle cell disease, Dupuytren's disease. There's all kinds of diseases that these programs cover. Different copay programs. So these are for commercially insured patients. And pretty much as long as you're commercially insured and you're on one of these drugs and there's a copay card program, they'll cover your out-of-pocket costs. Now, what's not on this slide is we've recently expanded into a lot of cardiology devices. It's only for uninsured patients, but Watchman, stents, pacemakers, anybody that's uninsured that needs one of those treatments, you know, there's a good chance that we can get it for them at no cost. Our whole goal here is to really use outside foundations, funding, manufacturer programs so that fewer patients fall to the hospital charity program and fewer patients are written off to bad debt. Now, this is a state of Mississippi. Is anybody from Mississippi in the room? I know there's only about 16 people that live in this state, right? I've got 2. I had 2 of them in the room earlier. But there's special funds out there for certain areas, and Mississippi and Georgia are 2 big ones. These will cover, you know, depending on a patient's income, things like $1,500 for a patient with Alzheimer's disease, $16,000 for breast cancer, $4,000 for colon cancer, It's closed right now, but last year, for most of the year, there was one that was $2,500 for patients with diabetes. Yeah. COPD, chronic heart failure. I think it's congestive heart failure, CHF. All these kinds of programs that will pay these patients medical bills, pay their treatment. Yeah.
How do they apply for that? Through
With Tiffany's company, we do it for them. They can go online and find it themselves and apply. Google is a wonderful thing, and I think ChatGPT is probably even better. But a lot of these people don't know they exist, and if they do apply, they get signed up, and that's great. But then you need to submit all kinds of things after the fact to get the bill paid. UB4s, 1,500 forms, EOBs. You try telling a 70-year-old patient with breast cancer that she needs to go and get her UB4 from her doctor. She's probably thinking you're going to ask for a shot, right? And so we take care of the billing for them. So Tiffany lives in a very, let's call it the out-of-pocket lottery. There's a lot of help for patients in her city, in her town, in her county, for all kinds of diseases.
I've got one other follow-up.
Yeah.
Specific to you.
Yeah.
Correctly. I used to be with a cancer center in Memphis, and we would see patients. Obviously, we had offices in Mississippi. Most states had the breast and cervical program to make patients automatically enroll. Mississippi was unique, and you're probably aware of this. If you have a breast cancer patient, if they were diagnosed already and had gone through a normal channel to get diagnosed for that, they wouldn't do it. The only way they could do the screening piece had actually go to a testing facility within Mississippi to get covered for that. And you really couldn't appeal it after the fact, which is very unfortunate. But are you aware of that? Has there been any change in lobbying that effort?
I'll have to look into that some more. Yeah, I'd love to know more about that. Yeah, sure.
Yes.
Yes.
This is a nationwide.
And it's not a one-time fund. Like, it's something that it opens up for them every year.
And is this on the CDC website?
No, they're in 1,000 different places, 30,000 different places. Yeah. Our software basically is, let's call it, scraped the internet and found them. Something as simple, we've got some people from a drug company in the room, and something as simple as, hey, this patient's on Injectafer. Is there an Injectafer copay card? We know that because, a new drug comes out. We keep an eye on it. We see what their copay program, their free drug program looks like. And we make sure it's part of our system. But yeah, so this is why there's a problem. So I apologize for these slides. These were, I gave them my slides, and they had to make them look like their slides. And it looks like, I don't know, they went through the washing machine or something. But qualification are complicated and difficult to navigate. Okay, question for Daisho Sankyo. Is that how I say it? I have a question. What's your federal poverty level to qualify for free Injectafer? 500%. Yep, but do you know, that's amazing, right? 500%. It is not that hard. You're a Medicare patient with a Medicare Advantage plan, and you have an out-of-pocket for $8,000. As long as your income, household of two, is below about $70,000, you'll qualify.
We make exceptions, but we can as well.
Yeah. Yeah. Like, nobody knows this.
But you can only do it for commercial, correct?
No, that's free drug.
That's not for free drugs.
Yeah.
So affordability gap, then that can be referred to foundation then. Okay.
Yeah.
I mean, I work with the OIG for
Yeah, that's the same thing.
really understand the process there. Right. And, we take cases that, unfortunately, where there's an off-label, maybe ambulance, we said recently before, where there's 21 courses of therapy, 155 files that have been sitting with their payer service team for about a year. And payer just continues to deny. This patient here to replace most of the files.
We had one patient a couple of years ago, 45-year-old man, 3 kids, physical therapist, wife was a physical therapist. And for whatever reason, he didn't sign up for a prescription drug plan. He was diagnosed, so he had a health plan, but no prescription drug plan through his employer. He was diagnosed with CML, and the doctor knew it. The doctor saw it before the testing was done. He knew he had CML. The doctor reached out to us and said, look, I know this patient's going to need this drug. It was, I think, Sprycel or one of those. It was a $16,000 drug. We got him the first month for free under a drug trial program. And then we started working with the sales rep, the drug sales rep at the hospital. It was October. And, you know, again, he earned this, that household income was like $150,000, $160,000, 3 kids. He's not poor. But guess what? You are poor if you have to buy your Sprycel for 2 months at $60,000 until your prescription drug plan kicks in. And we worked with the drug reps and we said, look, this guy has CML. He'll have insurance in January. We've got 1 month on the free drug trial program. And I'm like, the doctor, he won't take it. The doctor will have to put him on something else because he is not going to bankrupt his family or take a home equity loan out. If you look up how to pay patient bills, one of the first things they say is take out a home equity loan. And the drug rep came through, worked with us, was happy to do it. They covered the rest of the year for free, even though his income didn't qualify. It's one of those, I'm sure, one of those special exceptions. And, you know, he was able to start his CML treatment. He's alive today and there for his kids, all because 2 or 3 months of drug treatment needed to be covered, you know. But we had to fight for him. You know, we had to go to bat and work with the drug company and work out with the sales rep and work out how to do it. They wanted to help, but, you know, their rules. We just had to explain the situation. They made an exception and they got him covered. But it wasn't easy. So I'm not going to bother going through here with how we do this because it's nothing to do with sort of, this is more about hospital finance and all of that kind of stuff about what we do. So let's talk about some other support, because for the patient financial advocates in the room, this is really where it kicks in. But I'm actually going to ask Gail, I know you love to speak in public, to use an example that she talked about last night about a lady that was very sick and was more worried about her dog than she was. Would you mind telling the story? I'm so sorry. I did not warn her about this. But these are the kinds of programs that patient financial advocates can help with.
Good morning, everyone. I had a patient that was trying to make a decision between getting care for herself or getting care for her pet, her dog. And her dog had to have hip surgery. It was going to be a few $1,000s. And all she had was her dog. Like, she didn't have any close family. And she was, she pretty had made a decision amongst herself that she was going to get the dog care in place of herself because she couldn't live without this dog. And if she was going to die, they were going to die together, one or the other. And so I couldn't sleep that night after she had made this decision, because she didn't even want to accept any of the internal charity programs we had or anything. She just was more so worried about her dog. I did some research and found out that HealthWell actually has a fund for patients that have diagnosed with cancer and have a pet that has a need, because research has shown that if you have cancer, your pets aid in that healing process. And HealthWell actually, after the application, gave her $3,500 to go toward her pet. So when I came in that morning, first thing obviously I did was call her, and then she was more than willing to proceed with me going through getting her own foundation and assistance, but she did not want to get herself well without her dog being well. But just so you all know, HealthWell does have a lot of extra things out there besides just CPA assistance. They have a lot of other coverage for a lot of other things.
Thank you, Gail. I love that story from last night, so I wanted her to share. Medicare patients, this is really where those kinds of federal poverty levels come in. Your Medicare replacement plans, insane amounts of out-of-pockets. How do we get them their drugs when they show up to their specialty pharmacy, or they're told that before their drug is shipped or before they get it, they need to, pay $2,200 because they're in their donut hole window or they're in their whatever window, and that's what the drug's going to cost until they hit their $7,000 to $10,000 out-of-pocket. This was Eliquis, which I believe has just got on that new rule from President Biden that's going to come and be very cheap. But Eliquis is a very common drug that we help patients get for free, blood thinner drug, mostly because their Medicare replacement programs are just, they make it unaffordable for patients to get it. Oh, this is my favorite, employees.
Yes. So yeah, in our case, our hospital has, we have our own employee benefit plan. And so a big part of that is evaluating these prescriptions when they're coming through and deciding whose treatment gets approved and whose doesn't, you know. And so we want to create an opportunity for these patients to have as much access to care as possible. But some things are just, it's just too much. The system cannot support it. Because, you know, a self-funded plan, you know, it's the entire group that is supporting the, you know, one another. And so one case was an Acthar gel injection.
Does anybody know what this is, Acthar gel?
Yeah, so this was a patient, she was in pain, arthritis, severe pain. And this is not your first line treatment. This is after failure, after failure, after failure. And they finally resort to trying to get the patient approved for the Acthar. What's $40,000 for the injection? So our little plan can't sustain that.
That's every month, by the way.
Right. And so we would love to, but that's just not feasible. And so we had an opportunity where we could connect our patients with their team and they would take care of it.
Yeah, we got the patient approved Acthar gel. Acthar gel gets shipped to the patient's home every month. They inject it.
Yeah.
And
her rheumatologist was amazed because typically it's not even available for people. You know, they'll prescribe it and they'll say, you know, we probably won't be able to offer you this treatment, but we're going to try, you know, maybe we'll get lucky. And working in this manner, we created a way where there was no way. And so that's really the advocacy component of this that we're all kind of aspiring to.
Okay, and at the end of the day, you know, financial benefits. So this is, again, an older presentation. We started working almost a year ago now, but the first 2 months, we generated an additional $50,000 in additional profit for the hospital. That's money that went to this small little hospital, 50 grand, that covered patients' bills that weren't there before. 2 months, only 22 patients. It doesn't sound like a lot, but when you've got 22 patients that owe the hospital $50,000, you know, you think about it, that's $2,000 a patient in an area with a very high Medicaid and uninsured population. It makes a big difference to the community. We moved, we expanded. I would expect, actually we're almost at about $500,000 this year so far for the hospital in additional profit.